There are all kinds of opportunities for improving home care, making it more cost-effective, making it more reliable. Levels of care based on RISE scores, right? I mean, probably you can figure out most of what somebody needs by looking at their RISE score and who's at home with them, you know. So, can we do more care, less assessments? Probably. Can we provide more care through folks who are not health professionals, but well-trained? If we're able to provide physiologic monitoring through technologies, through basically iPhones, yeah, we can probably do a lot with coaching of personal support workers who have, you know, to professionals who have access to vital signs, et cetera. So I think there's a huge amount of opportunity in home care for providing better care, more care with the resources that we have today. And that's a huge focus of this plan. The other thing is that I didn't understand until I started wandering around the province, talking to home care providers, trying to figure out how it worked, was, you know, home care rationally depends upon other community support services. Depends upon availability of transportation. It depends upon availability of food through Meals on Wheels. It depends on volunteers coming to visit to end some of the social isolation that's, you know, that happens so often with folks becoming frail and so all those community support services previously were different from the services that were coordinated by home care coordinators. Well, now we're going to expect our home and community coordinators to look at all those services, bring them to bear. So I think we've got huge opportunity to improve the experience that people have with home and community care. That's one of the things that Nancy and I are really excited about, these two plans going forward simultaneously.
There was a review article in the New England Journal of Medicine about long-term home and community care a few weeks ago. Sort of surprising, since the New England generally doesn't have that as a topic they pay a lot of attention to. But it was a review of long-term home and community care and residential care in the U.S. And actually, the thing that struck me reading it was actually how the challenges they're facing in the U.S. in many respects are even greater than the challenges we're facing here. Because at least at the end of the day, everybody in Ontario has access to a long-term care bed if they need it. Everyone has access to some level of home care if they need it. But it made me wonder, reading that article, whether folks in the ministry sort of look to an example of a jurisdiction around the world where, or a couple of jurisdictions where you feel like people have figured it out. And it may be that the answer is nobody's figured it out, but I wonder whether there's sort of examples of sort of shining lights from various jurisdictions that you folks are looking at.
So Sharon Lee Smith, who's not here today, is Nancy, my partner, is responsible for developing a capacity plan for the province. You know, the 75,000 long-term care beds that are in the province currently, if you simply do a linear projection based on the demographics of the province, it would suggest there should be 190,000 long-term care beds, you know, in the year 2027, and after that a rapid fall off. Well, that's not feasible, right? I mean, we can't do that, nor do people want that. So there's been a change in long-term care, as you know, Irfan. The length of stay is reduced. The waiting times are reasonable across most of the province, 2 to 3 months waiting times for long-term care from community. That, by the way, is a function that will transfer to the LHINs. The process of approval for long-term care will remain part of that home and community care coordination responsibility. But the issue of what kinds of services we provide for people becoming both frailer and less cognitively capable is the real driver of the capacity plan. And when we look at jurisdictions that we can copy, we see a lot of different things. I mean, you know, the Scandinavians say they aren't building any long-term care homes, and it's true, but they're building supportive housing that, when you look at it, has elements of care associated with it. And that's an important thing for us, is to break through some of the definitions. Part of the problem that we're facing is the Long-Term Care Act. I don't know if you've seen it. It's got about 680 regulations associated with it. And it's a very structured, very well designed, but you know, it doesn't allow for a lot of innovation in the way that you provide care. So we're thinking a few things. First of all, patients want to stay in their home as long as possible. Nancy and I visited a couple of homes, and I remember one in particular, a gentleman who, you know, looked to me like he probably should be in long-term care, and his wife was even sicker, have both been living in their home supported by a couple of visits a day from personal support workers and once a week from a nurse for the last 2 years. And they haven't been in a hospital, and they're pretty sick people. And so, well, you know, do you ever, and one is, the wife had a respite visit to long-term care for 6 weeks. And, you know, our conversation with her, well, how was that? You know, were you happy to get home? She, oh, yeah, I was so happy to get home. Well, why were you so happy to get home? Well, basically, my husband, sort of. I like being with my husband. More importantly, I get my dog. And most importantly, I can have a cigarette. You know, and it's amazing how often the love of nicotine and nicotine addiction drives people. I guess I get there. You know, I want to have a scotch when I want to have a scotch, right? You know, it's part of the enjoyment of life. People want to have that freedom to make the choices they want to make within their home. They've had their whole lives. So, you know, people want to stay in their homes. We want to provide care in their homes. The availability of technology, OTN's a major provider. Our LHINs have been doing great work, e-shift, telehome care. These things are starting to demonstrate a real impact. But we also have to look at where the Americans are. You know, in terms of post-discharge, special nursing facilities that are so prevalent in the U.S. to prevent that period of immobilization that leads to progressive frailty in folks. You know, is that a model we should be looking at? We are looking at that model. The issue of supportive housing is a crucially important issue. So I think we have to look at creating new definitions, Irfan, and that's going to be part of what the LHINs can do. One of the great things, and you'll appreciate this as a health services researcher, once we get these LHIN subregions, won't it be cool to test innovation and then to look at cluster randomized implementation with evaluation across a variety of different, you know, geographies? We'll have probably 80 or 90.
I'm having a Pavlovian response. I heard cluster RCT.
Yeah, no, he's drooling in his microphone now. He's in danger of electrocuting himself. No, but can't you imagine that as being something?
I can.
Yeah, and I mean, now the other thing is, I'm going to mention HQO for a second, because I've got a huge amount of respect for the work that Josh and colleagues and Andreas are doing there. And one of the things we're really thinking about is the requirement for standardization of protocols across the province. We saw this in Cancer Care Ontario, where, you know, the standardization of care in 2001 was not very good. Clinical councils developing that actually put in place standards of practice, and people around that clinical council had the responsibility to then introduce that to their region. That's something that we're really looking at and talking with Health Quality Ontario about primary care, home and community care, community mental health. We think this is really important to use HQO's resources to develop standardization of care protocols.
Well, thanks. So I know people didn't come to hear me ask questions to Bob. So maybe I know Matt. I don't see him, but I think he's got a mic in his. Oh, there you are. So if folks have questions, please put up your hand, and Matt will bring you the mic. Oh.
Thanks. 2 points. This is very neat stuff, but the first is some research we did that's actually published in Longwoods indicates there is some risk when you're doing measurement and performance measurement of leaving out things that are difficult to measure or can't be controlled by the organization. And particularly for public health, there's a feeling right across the country that there can be some extraordinarily negative impacts of only chasing the things that are easy to measure and easy to control. And that's just a caution. The thing I'm wondering about the LHINs and the sub-LHINs is the boundaries in Toronto don't necessarily match how people get care. People may go to primary care near where they work as opposed to where they live. You also mentioned Cancer Care Ontario, and presumably they're not just serving LHINs that they happen to be in, similarly hospital for sick children. How are you going to accommodate the fact, also ethnocultural, people may go for care where they can speak their language and understand the culture. If you're going to try to organize it on LHIN and sub-LHIN boundaries, how are you going to match the fact that how people get care may not necessarily match those boundaries?
So a few things. First of all, we're not going to disrupt any relationships that already exist. Obviously, if your primary care provider is 2 LHINs over, so be it. If that's a great relationship, continue it. The first thing is we need a standardized way of attaching people to the services in their selected postal code. Now, could those services be related to your postal code of employment? No reason why not. So your primary care provider could be close to your work? Absolutely. People will have the freedom to choose where they want to receive services. However, this organizes our system. You know, our system up to now has sort of been organized around the postal code of the provider. Now it's going to be organized around the postal code of the patient. So if you want home and community care, presumably you're going to be a stage of your life where you have this postal code where you live as being the place you want to have services provided. So, you know, that's pretty straightforward. If you want to have services provided some other place, you know, we're not going to fight you. But we want to organize services and design services around the average. The average person we know wants to get services close to where they live. Toronto always has pointed out as well, how can you organize Toronto, right? How can you, well actually Toronto breaks down like every other part of the province does. Most people, you know, I used to work across the street at UHN. UHN, about 60% of its activity is big community hospital, right? And it serves people who live downtown, and it serves people who live in the regions around it. And those people, you know, will have primary care providers in that region as well. You know, in terms of limb boundaries, that's an issue. In terms of, you know, public health overlapping with limb boundaries, we recognize that's not always perfect. But, you know, the situation that exists in the city of Toronto is actually perfect. The medical officer of health, spectacular guy, international leader, sits at the LHIN table, gives advice to the LHIN. That's what we want to see happen. That happens in North Simcoe, Muskoka. Great. Chuck Gardner is the medical officer of health for that region, sits at the LHIN planning table. You know, other parts of the province is kind of broken up and the boundaries don't overlap, but those public health units will select one person to represent them sitting at the LHIN table. I mean, this is not rocket science by any means. You don't have to have perfect overlap. Are we flexible in terms of LHIN boundaries? Absolutely. Do we have to reorganize all LHIN boundaries by day one? No. It can happen subsequent to that. So I think the crucial change here is saying you select your postal code where you want to receive services, and we will tell you how services are designed for that postal code. If you move into a postal code and you want to get a primary care provider, we will have some central process. Don't know exactly what it is yet. Probably, I think it'd be cool to have one number to call in Ontario. That gives you access to that local, you know, then would break down from that call center to something local. But I don't see a geographic issue. Now, I'm just kidding. May I have 2 more minutes? Do you mind?
Sure.